It's our first of 2025, and we're pleased to have Dr. Elizabeth Jasper from Vanderbilt University Medical Center presenting today on community engagement studies. Dr. Jasper is an assistant professor in the Division of Quantitative and Clinical Sciences in the Department of Obstetrics and Gynecology at Vanderbilt University Medical Center. She received a PhD in epidemiology from the University of Iowa in 2019 and completed postdoctoral research fellowship in Vanderbilt Genomic Medicine Training Program as a T32 fellow. As an early career faculty member at Vanderbilt University Medical Center, she has become a faculty scholar in Vanderbilt's Building Interdisciplinary Research Career in Women's Health, or their Birch WH award, and is a Precision Therapeutics Academy trainee for our Vice MPRINT Center of Excellence in Therapeutic. With that, we thank Dr. Jasper for her presentation today on community engagement studies, a tool for enhancing pharmacogenetic study design. Turn it over to you, Dr. Jasper.
Thank you for that lovely introduction, Sarah. Feel free to stop me at any time for questions, either in the chat or unmute yourself if that's possible. But like Sarah said, I'm going to be talking today about community engagement studios as a way for us to enhance our research and study design, not just in pharmacogenetics, but I'll use an example from MPRINT in a pharmacogenetic study. So I'm just going to start with a little bit of background to kind of demonstrate the research gaps and frame how we use community engagement studios. So I think we all know in the US, the majority of pharmacogenetic, or not just in the US, in the world, the majority of pharmacogenetic and genetic research is conducted in older adult populations, primarily of European ancestry. Children, pregnant persons, and people of color are often underrepresented in this type of research. But we know that including diverse and special populations is necessary to not only just improve health equity, but also validate previous pharmacogenetic associations and to be able to provide appropriate recommendations and guidance to prescribers. As you can imagine, though, due to a history of unethical research and ongoing social inequities, there are barriers sometimes to recruiting specific populations like children, pregnant individuals, and people of color. And like I said, this isn't really an issue that's specific to pharmacogenetic research. It really permeates all types and all aspects of healthcare and research. Mistrust of the healthcare system in the US and research is really common. A previous study found that about 1/3 of respondents agreed or strongly agreed that it was possible that people were conducting medical experiments on them and they wouldn't know. So further indicating kind of mistrust or misunderstanding of the medical research enterprise. And the NIH has previously identified mistrust and lack of understanding as critical barriers to research participation. It's estimated that only about 15% of individuals in the US participate in a research study. And that's really evident in clinical trials, and particularly with, I think in the late 2000s, it's probably even different now, but in the late 2000s, about 1/3 of over 100 clinical trials were able to recruit their targeted number of participants in the time frame they originally specified. But obviously, difficulty recruiting participants delays our research. It makes it more costly, it reduces funds for our future work, and it delays translation or development of new knowledge. And we know that translating research in particular is hard because it takes a rough estimate, an average of 17 years to translate our findings into clinical research. So it's kind of further delaying translation. But we do know that engaging communities, kind of building trust, demonstrating respect, and understanding the community our research impacts and their perspective may help to kind of overcome recruitment barriers and improve our research quality, its translatability, and its relevance as well. So brief background, I'll focus in on a very narrow part right here, community engagement studios, of this wonderful graphic that was created by some people at Vanderbilt, and the citation is on screen. But community engagement research is really a collaborative process. It involves community members, often referred to as experts or stakeholders, in the research process. It's ongoing and iterative, and it incorporates input from people who the research outcomes will impact. And it's about building that trust, those partnerships. It can take many forms, like you can see on screen. It's not a one-size-fits-all method, and really depends on the aims and the goals of your research. So these are a couple of examples of community engaged research on the screen. The extent of engagement right here, the number or the types of stakeholders and the level of involvement can vary, but the ultimate goal is really to address issues that affect the well-being of the community members that are involved in this. So the number of the stakeholders engaged and the extent of the engagement should, like I said, match the goals and your aims of your study. The roles that the stakeholders can have are really spanning a continuum, going from really highly involved up here at the top of the pyramid, where they serve as principal investigators or co-investigators in our research and help lead it, so taking on a lot of research roles, all the way down here to kind of a brief one-time targeted input. And the experience and the training that our stakeholders need will obviously vary based on this continuum of their roles. And when community engagement research takes place in terms of the study design can actually vary. So they could be involved in creating the research question, perhaps up here in as a principal investigator, or serving on a community advisory board, so driving the research, or refining study materials, helping to recruit other participants. But I'm going to focus in on one today that we used for Vice MPRINT as we were developing one of our projects. So again, like we know from previous literature, that no matter what type of engagement method, extent, number of stakeholders, or the level of involvement, involving communities always has a benefit. It increases relevance, it increases speed of translation, and can improve health outcomes and make sure our research really matters to the people that we're researching and who it will impact. However, many of us lack training to effectively engage stakeholders, and academic institutions might lack the infrastructure to be able to support this type of research and community engagement in general. So I'm just going to highlight one that we have at Vanderbilt, the Community Engagement Studio, or CES. I'll just give a little bit of overview on what they are, and then discuss how the Vanderbilt Integrated Center of Excellence in Maternal and Pediatric Precision Therapeutics, or Vice MPRINT, use this in one of our studies. But keep in mind that as I talk about the process and the example I'm using, the methods are a little specific to Vanderbilt, so they could vary from institute to institute, but as we'll see at the end, there are several other institutes and national resources to be able to perform community engagement research and community engagement studios. So CES were developed by the Mary Hall Vanderbilt Community Engaging Research Corps as one method to engage communities in our research all the way back in 2009. So they're a structured program, kind of like a non-research focus group, that facilitates project-specific input from community and patient stakeholders to enhance our design of our research, the implementation and dissemination of our findings. And they are specifically tailored to your population of interest that you'll be studying. So during a CES, stakeholders are sharing their advice and their opinions based on their lived experiences, which is really important. And like I said previously, it can be used, their feedback, in efforts to improve the research process at any stage. So what's the difference then between a community engagement studio and a focus group? So community engagement studio, the purpose is really to get guidance, to get feedback, to inform research, and it's a dialogue. So it's bidirectional, although we'll talk about in a second, researchers are coached on how to facilitate conversation and really to change the dynamics. So it's not just us talking at people, but us listening more. And they serve as consultants, the participants, rather than a focus group where they're research participants. Other kind of distinctions of note that aren't necessarily on this slide are that CS experts may give you written or oral comments and can request additional information from you, can ask you questions. They can question your research approach, your process, your questions, and they can scrutinize topics that you didn't anticipate, and they can be contacted later after the session if you would like and if need be. In comparison, a focus group has IRB approved questions or a script that you have to go off of. The informed consent is obtained and the themes are identified and connected with participants. There's no contact afterwards. It's a one-time thing. So the process of a community engagement studio is seen on screen along with the citation of the very first original paper that outlined the program here at Vanderbilt. So real briefly, the process here is starting with a facilitated meeting where we're introduced to the facilitators, and really we're asking them to help us conduct a CES. We meet with them once to clarify our research question and determine who we need, what our experts and community stakeholders look like, who they are, what their lived experiences would be for our study, so they can help go out into the community and recruit these people for the CES. And then we also get engaged in, or we get coached on how to engage and how to speak with non-researchers. And they help us create a participant-friendly, short 10-minute presentation, kind of outlining the important parts of our study. So when it comes to the facilitated meeting, they start with an introduction of the community experts, the facilitators, and the researchers, with two members of our research team that are normally present or, as we'll see in a second, on camera. And then it's the short presentation that I'll describe in a bit. The purpose of the study is included, why we researchers think it's important to the community and what impact or benefit or risk it could have on them, why we're focusing on this specific population, a little bit about the study design, what we're going to be measuring, and how we're going to actually use the findings, how it's going to be translated for community use. Oops. Sorry about that. So the facilitator will ask questions of our community experts, and really investigators only talk when a question is asked of them or clarification is asked on something. And then after the meeting, facilitators provide researchers with a summary. If it's virtual, maybe a recording or often written summary of how the meeting went and recommendations based on stakeholders' views. I should note that stakeholders are given relevant study materials like recruitment materials, so your consent forms, in our case, a survey prior to the meeting so that they can look over this. And community stakeholders often meet with the facilitators or the CES team to kind of go over, if they're new to this process, if they've never been in one before, what it's like and how it functions and what's expected. So a CES can take two formats, in person and virtual. So we participated in a virtual one because it was right in the middle of the COVID pandemic, unfortunately. So we used Zoom. The sessions were recorded for note-taking. Experts could use a chat as a way to kind of further discussion as discussion was going on screen as well. And importantly, compensation is always provided to our community experts. And then, like I said, we get a summary. The real difference, obviously, in person, you're all together at a community space. A meal's often provided, and we have like a whiteboard to really reiterate key points provided. So I'm just going to highlight one way we can use it to kind of further set this example of community engagement studios and how important they can be for you. So we used it with Vice MPRINT's Project 1 AIM 1, which is on the knowledge and attitudes about pharmacogenetic testing among pregnant persons and then children with chronic conditions and their family. So we discussed already at the beginning, major limitation of this type of research is it's largely in adults of European ancestry. We utilized two community engagement studios as we were planning Project 1 AIM 1 because we really wanted with the project as well as kind of the studios as well to illuminate their knowledge, particularly in this group of children and pregnant persons of diverse backgrounds. So for context, I'm just going to kind of outline the study as this is what kind of we give to the community experts during a CES. So you'll see what they see. This is the outline of our study procedures from a participant's point of view. So we plan or have enrolled two different populations. Like I said, the pregnant persons and children with chronic conditions, plus their parents, obviously, if they're not old enough. And we had a special emphasis on including people of color. So obviously they're first screened if they qualify, and then if they qualify, they're asked for consent or assent or parental consent as applicable. And then they immediately are able to complete a baseline survey online. We use RedCap for that. And that baseline survey includes a section on their basic demographics, socioeconomic factors, health, a lot about their medications that they use or their history of medication use. And then for the pregnant population, a little extra section on their pregnancy history or their reproductive history. And with our surveys, we're really trying to capture 6 specific domains: their experience with medications and their side effects, kind of their understanding of genetics or pharmacogenetic testing, their perceptions of how pharmacogenetic information could be useful, the impact of testing on their relationships with their healthcare providers, and then scenarios where pharmacogenomic guided prescribing could be helpful or not. And then we did also develop an educational video. So we wanted to see if that helped them understand pharmacogenetic testing and their test results. So after they kind of complete that baseline with all those domains that we have embedded in the research questions, they're actually given pharmacogenetic testing panel, and their results, when they're ready, are uploaded into the My Health at Vanderbilt patient portal. Oop. And then they complete a follow-up survey after that. Whether they get 1 or 2 surveys depends on randomization. So they can be randomized and get the video and the survey at the same time, immediately after they get their results uploaded into their patient portal, or they can get a survey, wait a little bit, then get the survey and the educational video. And like I said, that's kind of to look at, does the pharmacogenetic testing, receiving it, and getting the information in your healthcare portal really make an impact on your knowledge and attitudes? Or does the educational video, or do they both make an impact? So we, as we were planning our study, reached out to the CES team to do two community engagement studios because we wanted to ensure we were reaching the population that we intended to. So we wanted targeted recruitment, that we're communicating in appropriate, comfortable ways, and that we captured lived experiences accurately. So we have everything in our survey that needs to be there. So we asked for some feedback on our study materials. And I will just briefly describe the CES process, but in the example of our R2 CES. So we had our planning meeting, the 1-hour meeting with the facilitators, where we, the research team, met with the facilitators. And they are people that are specifically trained in community engagement. And they have numerous connections to the community, whether that be through church, through interest groups, through schools. And they help us work through kind of our main research questions and create that short 10-minute stakeholder-friendly presentation to give at the start of the CES. So in our meetings, we decided we needed two community engagement studios, and they help us focus to pinpoint our discussion on recruitment and participation in this type of research, and then feedback of our materials and how genetic testing should be returned. The test results should be returned to people. So we decided we need two community engagement studios because we had those two separate arms of our study. The pregnant persons, or in this case, parents, because we know that if you have a newborn or you're pregnant, you might not have the time right away. So we did have parents of toddlers in that studio. And then we had a community engagement studio with parents of children with chronic conditions as well. So the advantage of using a structured program like CES's at Vanderbilt is that our clinical translational research, or VICTOR, has a streamlined process for this with those facilitators who are specifically trained in this and facilitating discussion. And they're out in the community. They have combined, and one of them, I think, has over 12 years of experience of doing this. And they recruited for our specific CES in a variety of ways. So they pull from people who previously participated in a CES, but that match our targeted populations. And they were, in the past, interested in doing more. They also use social media, especially groups of parents with children with specific chronic conditions. So Facebook moms groups or support groups, health advocacy groups. And then they also did some internal recruitment, so within Vanderbilt University Medical Center. So for implementation, they did the individual recruitment and screening. And like I said, they get an orientation if this is their first one they've ever participated in beforehand. They do everything from the scheduling confirmations to reminders, if it's virtual, to setting up the virtual format and the links to that. For ours, there were over 42 people who completed the screener that said they were really interested in participating in these two community engagement studios. 23 of them were pregnant people or new parents, and 18 of them were parents of children with chronic health conditions. And these were a range of chronic health conditions. So I know we had some individuals whose children had diabetes. There was sickle cell, severe asthma, autism, some seizure disorders. There were quite a few of them. So for our study, we gave the community experts our surveys and a script of the educational video that we hadn't created yet because we wanted some specific feedback on that before we created it. So we just provided the script. Our pregnant studio, there were 4 females, 3 with very young children and 1 who was also a parent, so could have gone in the other studio as well, of a child with a chronic condition. All of them identified as African American or Black, and most of them were between 30 and 50 years of age. And we had real diversity in terms of education and income in this group. And then for the parent studio, we had 6 female participants, 2 identified as African American or Black, and 4 as white. And they also ranged in age between 30 and 55. We had 1 who is a little bit older than 55. And then, like I said previously, their children had a variety of chronic conditions, some with multiple. So we are allowed to take notes as researchers during our community engagement studio, and we did. But the nice part about, again, using a structured program like this is that we received PDF. This is the first page of the PDF, with a detailed summary of the conversation and the questions that the community experts had, as well as their overall feedback and recommendations too. So to me as a researcher, this was one of the best things I've done in my career. I really enjoyed and appreciated the opportunity to hear from our community experts, their experience, and get their feedback. They brought up a lot of things I wouldn't think of, and we'll kind of go over them in the next couple slides. But in general, I think everyone in both studios were kind of interested in genetic and pharmacogenetic testing and enthusiastic about participating in our study, but they're apprehensive. So we had some great quotes that came out of this. So one person said, "I think this is really interesting. I would want for my child to know what medications would work best for them. If there's a way to get that information, I would be for it." Or they didn't know it was an option, but it would be nice to take that trial and error out of the process of medication prescribing. And then families' preference for holistic approaches were kind of mentioned multiple times, as well as the fear of being experimented on. But they did think it could be helpful in certain situations specifically. So one individual brought up that their child's father was adopted, so they felt that this would really be helpful when they knew, nothing about the medical history of one side of the family. Or another brought up that medical history, family history is really not talked about, or the older family members never went to a doctor. So genetic information, genetic testing could really help fill in unknowns or gaps in family health history. And for those with children with chronic conditions, experts stated that really this would potentially alleviate a lot of stress and worry. And in that second studio of the parents with children with chronic conditions, they had a lot of very technical questions. They asked about things like the test validity, the error rates, sensitivity, how many times this would have to be done on their child, how much blood would we need to take. So they were kind of very knowledgeable about these things. But in the end, kind of both studios, or experts in both studios, thought it would be really helpful to know what medications would work best for them or any potential issues beforehand. Again, citing that previous trial and error for their children's medications. And one parent said they have to take so many drugs. I think having the genetics would help narrow down which medication would work best for them. If you're in a stressful situation, and this could alleviate the stress and some of the emotions for the parents. So community members pointed out several concerns with the study, as well as barriers to participation. of the population, there was a lot of discussion on how the genetic information would be used beyond the immediate study, whether it was stored, whether it could be used for other research that wasn't specified. And we heard from them kind of persistent fears of being experimented on by the medical community as well. And we kind of learned that these fears intersected in our study in two ways. First, there were fears about, in general, participating in research strategies, and they gave us some suggestions on how to overcome those fears, but also they brought up that clinicians can take a trial and error approach to finding the right medication or dose for a patient, and they can also perceive this as experimentation. So again, they thought that maybe pharmacogenetic testing could prevent that type of experimentation, and it'd be better to have that information up front for a patient. So they cited really it's a lack of communication and information from healthcare providers and we as researchers that contributed to their own and their community's skepticism. And regarding overcoming the fear of being in a research study, both community engagement studio groups emphasize, the importance of clarity and transparency, in both interpersonal communications, but also in our documents, especially that informed consent document, to overcome any participation hesitancy and mistrust of the research team. They really stressed the importance of being able to convey information to patients in an understandable way and being able to relate to a patient. And one new mom said, I feel like some people think we're dumb. We might not know every intricate term and what kind of microscope to use, but we're not stupid. If you explain it in a clear way, we can understand. You have to take that medical term and translate it into community members' language. So we had a ton of great feedback centered on recruitment for participants who had less of a relationship with their healthcare provider or didn't necessarily have a primary healthcare provider. They suggested that we recruit in common areas, so informal notices in healthcare settings like near an elevator or a waiting room or on the tables at waiting rooms or using social media groups, notices in their electronic health records, so that my Health at Vanderbilt patient portal I mentioned earlier. They suggested all of those less direct methods for recruitment. Recruitment by referral from pediatricians and obstetricians was the method that was preferred for people who had a primary healthcare provider and really described their relationship with that healthcare provider as very good. So, like I said, we gave them our survey and the educational video script. And in terms of terminology we wanted input on the terminology and the overall readability of our study materials. And something I didn't think about, I don't think many of us thought about going into this, they expressed some concerns over some of our baseline questions, mainly about religion and family history, income, and marital status, and asked us for clarification on that. And after discussion, putting clarification on that in our survey as like a header beforehand. And then another thing I didn't really think about that our community stakeholders brought up is which providers would actually have access to their pharmacogenetic results if they participated in the study. One person said, what if I want to trash the results? And what if I don't want my kid's doctor to see them? Or I wouldn't want my psychologist to have access to them. And then we have questions in our survey about feelings in those follow-up surveys after they received test results. And those caused a little bit of concern for CES participants. They said things like, what if the parent feels like I was really hoping that one miracle drug would be out there to help my kid, and they don't get that? Or they thought there were some kind of heavy philosophical questions, and would we educate them about the results beforehand? Are we having those conversations with them? And then again, another thing I never really thought about, because I think I use them interchangeably when I talk, is the use of the word medication over medicine. One person said, medication or medicine's like an umbrella term. That could be cough drops or supplements. But medication is something that's prescribed by your doctor. And then, like I said, we hadn't created our educational video yet. We had the script ready for it, but we asked them some questions on the script, and they said they wanted a woman's voice over a man's voice to narrate it. And we have a section on metabolizer status, and they wanted clarification in the video on ultra rapid versus slow, since we had a little graphic of kind of like a stop sign, and it was not intuitive. They said that faster seems better, ultra rapid sounds great, but you're telling me it's not a good thing. Most people want it to kick in faster. So they had feedback to provide more clear definitions on that metabolizer status with respect to enzyme function. So, like I said, we got that great little PDF at the end of our community engagement studios where they had our recommendations, and the use of our community engagement studios really, really helped us modify our recruitment methods and our research materials to more effectively communicate and engage with populations that are currently very underrepresented in pharmacogenetic research. So this experience and hearing from stakeholders really changed the way we ask several questions, how we think about certain variables, and like I said, with our recruitment and the methods they suggested, like using My Health at Vanderbilt, which is something we did as we recruited. So this process, describing it is, for this specific example, is published. You can find the paper online or reach out to me if you would like it specifically. But there are a variety of resources. I don't know if you can see my mouse, but down here in the right is a great article by individuals at Vanderbilt about community engagement research, where that graphic is from on the different types and ways to engage communities. But then there are also research studies describing community engagement studios from other institutes. So I know one of these, I think, is from Penn State. They have their own core that I think does community engagement studios. And many of the University of California locations also have community engagement studios and people trained in the infrastructure in doing community engaged research. But there are also a lot of great national institutes. So this was describing kind of Vanderbilt and Mary Hall Medical College ways to do it, but the NIH has a Community Engagement Alliance. Obviously, there's now the All of Us research program, and there's things like Research Match that can help you. But one I really want to kind of highlight, there we go, is the Patient-Centered Outcomes Research Institute. They have funding opportunities, but really also great resources to learn about all the different ways you can do community engagement and perform stakeholder-driven research. So I really recommend, there's the link on the screen, going there if you're interested in community engagement to kind of learn more about the potential processes and even more resources out there that can help you perform community engaged research. All right, so in conclusion, involving communities in any stage or all stages of our research really increases equity. And it also increases our research quality and its impact, as well as how fast we can translate that to change clinical practice. The community engagement studio model that we discussed today is really just one of many potential methods but is applicable to all phases of research. And ours was just the example of using it to help us guide our study as we were still in the process of creating it. And engaging communities and community engagement studios also have obviously implications for our guidelines and our clinical practice. So I'd just like to thank the Vice MPRINT PIs, Prince and Digna, as well as the Project One AIM-1 study team, but most importantly, the community engagement experts, the stakeholders. They were incredible, and the team seen on screen, especially Tiffany, who was our facilitator for both CESs, and then also our funders for Vice MPRINT and for me personally, Birch. And then I will take any questions or comments.
Elizabeth, that was a great talk and very interesting. If our audience has questions or comments, please feel free to utilize the Q&A box or the chat box, or simply raise your hand and we'll promote you to be able to ask your question or participate in the discussion. So while we're waiting for that, I do have a few questions that to ask of Elizabeth. You know, you ran two different sessions focused on, you know, one on pregnant individuals and the other on the pediatric population. As an investigator, did you learn or make changes between your first and second experiences with the community engagement studios?
That's a great question. I think going into the first one, I believe that was with the parents, or no, the pregnant persons or the new parents. I think I was probably definitely, you know, more quiet, and I didn't know what to expect. I think we did update our slides a little bit after some feedback for that first 10-minute presentation with some clarification on our research process and our target population, especially for that CES with the parents of children with chronic conditions. So I think, you know, experiencing something for the first time, I didn't know what to expect, but after the first time, really loved it and enjoyed it, and knew going into it what it would be like. So yeah, we definitely made some changes after the first one.
What most surprised you about the sessions or any of the feedback that you got? I know you went through some things, and I was kind of, you know, interested in your comment that, you know, I don't want my psychologist to know
Yeah.
what
I
my
never
genetics.
thought of that. Like my medical record, who has access to it, I never really think about how every doctor at like Vanderbilt could see mine. So that was something I just didn't think about. They've just brought up all these good points I never think about, like who has access to it, or the use of medication versus medicine. But I was also very surprised when we were doing the community engagement studio with the parents of children with chronic conditions, because a lot of the conversation turned to very technical things like that, specifically how many vials of blood and how much blood would you need from their child, because their child's often, you know, pricked for a lot of other things. Can you do it at the same time? Does it have to be a different prick, or do they have to perform it a number of times, and like what specifically is on the panel? So that really surprised me, because I didn't think about, you know, some of those things going in.
You may have mentioned this, and I missed it. Is there an optimal size for the number of participants in these sessions, and how are those selected then?
Yes. So at Vanderbilt, the community engagement studio team and the facilitators help you decide on how many, but I think they keep it under 10 for the most part. It's a little bit different when it's virtual, because obviously that format with discussion is a little different. And I think potentially more challenging to facilitate a discussion virtually than in person. So ours were probably a little bit smaller, but they're kind of trained to know kind of when the cutoff is, but I think in general, it's not more than, 8 or 10, I think, in one community engagement studio.
And then I guess the other question is for the same project or question, is it worth having multiple community engagement studios to get varying inputs, or is it typically is one sufficient for the questions you have?
I think in our case, two was necessary because they were different populations. Different concerns were brought up each time, different suggestions for recruitment or clarification were brought up each time. I think I think two or more could be very helpful depending on, how the first one goes and what stage you're using it at in your research. So with us, we had, already had our research question. We were refining, we had our survey ready to go and the script ready to go, but we wanted to make sure, we could recruit these populations and we were communicating effectively and in an understandable way. Our community engagement studios went really great and they had wonderful feedback, but no one, said this is a horrible, horrible idea, redo everything. So I think if there are more suggestions or suggestions that you can't change, then I definitely think more than one could be helpful.
See in the chat, we have a question from IO. Mistrust has been a huge barrier in our patient recruitment efforts. How can research coordinators increase the trust between the provider and the patients, or trust in the systems?
Yeah, it's a hard question. I don't think there's a one thing that's going to make it easier. I do think things like a community engagement studio, engaging with the community in any way you can, really helps, especially at your institute. If you're recruiting at your institute from a specific population, making those connections with your target population really helps. Because like I said, at the beginning of the slide, you can potentially use them to help you recruit for your studies or things like that. But I think with the trust, it's definitely hard given so many social inequities and just the history of research and some of the horrible things that researchers have done. It's hard to restore trust, right? So I think, like our participants said, it's really clarifying the language, being very intentional in who you're recruiting and how you're talking to them. But I don't think anything can really beat kind of engaging with the community in a face-to-face conversation to kind of understand where they're coming from and what's important.
Thank you. I don't see any other questions coming in. So with that, I'll thank Dr. Jasper for her engaging talk on community engagement. And this video will be posted to our MPRINT YouTube channel in the next few days for those who would like to share it with colleagues or review it again. And I'm sure Dr. Jasper would be happy to talk to you more about her experience with community engagement as well. Just a couple of upcoming events on our MPRINT calendar. Our next MPRINT webinar will be on February 20th, focusing on MPRINT resources, how to access and some of the consulting support we have available through our MPRINT Hub will be discussed there. And then we also invite everyone to join us for our annual meeting that will be at Vanderbilt University Medical Center May 14th and 15th. And the more information on our annual meeting will be released soon. So keep an eye on our website and social media pages for the registration there. So with that, thank everyone for joining us today and have a good weekend.
Thanks for having me.
Thank you.
Thank you.